Dr. Morrison, thank you so much for joining us today.
My pleasure, sir.
You were president of the Academy at 2010. Tell us a little bit about the challenges you've faced and sort of where you see us today.
I think the biggest challenge during that year was beginning to think of palliative care as not just care for people right at the end of life, but care that was appropriate for all persons with serious illness and their families. And we, going before 2010, had made a remarkable shift in changing both the field's perception, our colleagues' perception, and we're beginning to change public perception about the appropriate role of both palliative care and hospice in taking care of people with serious illness. And I think the biggest challenge that the Academy faced during the year that I was president was when a very forward-thinking bill to promote advanced care planning went forward in the House and was immediately labeled as death panels, and that we were going to, and the tarring of any type of care that was focused on persons with serious illness, persons at the end of life, persons who are actively dying, being labeled as potentially rationing or going through a death panel. And I think that the challenge that at the Academy we faced was, how did we confront this? And how did we get our message out that what we were providing was really high quality, compassionate clinical care that was not actually shortening life, but all the data that we have and subsequently shows that it prolongs life, and how to get that message across. And I think the biggest mistake that I made as president back then was thinking that this is so ridiculous that it's going to go away. Yeah. That when we thought about it initially, we thought, this is just so ridiculous.
Yes.
Our best response is no response. And in hindsight, we should have been way out in front of it. And I think what it did was it set a number of our efforts back, at least until this year and the recent presidential election, because at least for the first term, the first Obama term, anything that looked at end-of-life care was buried in Congress because of the worry of it being labeled death panels. And I think that was the biggest challenge that I faced that year as president.
Wow. And as you have seen the Academy move forward in the last few years, how do you see us positioning ourselves, and what should we be looking at?
I think, I see us quite honestly in our field as the solution to the healthcare crisis. When you think about who are driving healthcare costs, it's 5% of our sickest patients who drive over 50% of Medicare costs. And when we look at all of these new organizations, whether it be ACOs, whether it be medical homes, whether it be patient-centered medical homes, also medical homes, whether it be bundled payments, the people who are going to be driving those costs and the people who we know are getting the worst care are our patient population. So what do I see as the Academy over the past? We are the solution because we're the group that knows how to manage the pain and other symptoms, stress of a serious illness. We know how to communicate. We know effectively how to match treatments to patients' goals so that we reduce misutilization. We know how to coordinate care. And we know how to coordinate care for the most complex, the sickest, most vulnerable population. We're the experts. And I can't see any of these new organizations succeeding without well-integrated hospice and palliative care. And I think that as the opportunity for the Academy, the growth that we've seen in Academy membership as a result of that, the growth in the field, the interest in palliative care, all relates to this opportunity that's brought about by healthcare reform. And I'm very excited about what the future is going to mean for us. I mean, the challenge is going to be we don't have enough people to fill those positions, the workforce issue, but I think we're just in a terrific state.
Well, what a great view of the future. As our leaders coming along are going to need some comprehensive skill sets. How would you sort of describe what the leaders of the next generation are going to need?
I think they're going to need, and I think it's going to vary, but I think they're going to need three things. I think for our clinical leaders, they're going to need, obviously, high-quality clinical skills. And, the days of being able to practice palliative medicine, let me rephrase that. The days of being able to practice palliative medicine in the future without fellowship training are gone.
Yeah.
That the idea that you can go out and just learn it on the fly, forget about it. That was our generation. So they're going to need to be fellowship trained. They're going to be board certified. They're going to need to have very good administrative skills, because we know that we will never have enough specialists to take care of every person with serious illness. So we're going to have to be able to do both integration within systems, do systems-based care so that we take care of the sickest, the most complex, the most vulnerable, and that our routine health care takes care of most of the patients with serious illness at a much higher level than we're doing now. And they're going to need to be educators, because the ability to translate what we do to medical students, to medical residents, to practicing physicians is key to improving the care of people with serious illness. So that's, I think, our clinician, what I would say our clinician educators and our practicing physicians. And I look at that both within academic medical centers, within hospice, and within community-based palliative care teams, that they are going to have those three skills. Our leaders are going to have those three skills. Our researchers are going to have to be able to have the knowledge and skills to compete successfully at NIH, so that we rapidly ramp up the evidence base. Our researchers are going to have to be very pragmatic. I mean, there is this culture in medical research that the individual researcher should be focused on what interests him or her, and that hypothesis should be driven in. We can't afford that in our field, that our evidence base is so inadequate compared to what our patients and families deserve that we can't afford to do that. We need to be focused on the key problems that are facing our patients and families. And so our researchers need to be pragmatic. And the third piece is they need to be collaborative, that we need to be doing research that integrates both within our field, but into oncology, into cardiology, into pulmonary critical care. Again, because the workforce issue, that we need to be able to doing the work that can be integrated and translated. And finally, all of those people need to have skills in advocacy, that we need to have, our patients are so sick, their families are so overwhelmed, that they will never be able to be the advocates for themselves. They're not going to be the young mother who says, I wish I didn't have a C-section. They're not going to be the partners of people with AIDS in early stage AIDS who formed ACT UP and made change in Congress. The people who have to advocate, who are going to be advocating for our population, are going to be their physicians. So we have to be able to learn to advocate, to influence legislation, to work on policy, to make change, because nobody else is going to do it for our patients and families if we don't.
Wow, sounds like quite a challenge for the future.
You say that, but it's not. I mean, if you think about where the field was in 2000, or even in 1995, when support came out, when Jack Kevorkian was the alternative to, traditional medical care. If you think about where the field has come in literally 15 years, and we've gone from, less than 5% of hospitals having palliative care teams to now 87% of our largest hospitals. When you look at, 20% of people having hospice before death to close to 50%, half the population now accesses hospice before they die. These are not insurmountable challenges that we can't achieve in, 5 to 7 years. I mean, when you think about what we've done over 15, these are actually pretty small challenges for 5 or 7, quite honestly.
Wow. Wow. What a great perspective. Any other thoughts to share?
No, I think the one thought I would have to share is that this is just a huge opportunity, but also a great time for our field. That we have the caliber and quality of young physicians who are applying to our fellowship programs, graduating, joining the academy, is something that we have never seen before. And, you know, we've gone from the privileged outsider to mainstream.
Yeah.
And that is, again, both a remarkable achievement, but more importantly, it's what our seriously ill patients and their families need. And I just see continued growth in that area. I think that we are at a very, you know, people talk about the tipping point. We're well past the tipping point. It's our role now to sort of consolidate it so that everybody gets the health care that they deserve, and quite honestly, what you and I get when we're older.
Amen, brother. Thanks so much.
Thanks, Porter.
I really appreciate it.
My pleasure.